Hi everyone, today I'll try to simplify the diagnosis of intracranial hematoma and MRI. The diagnosis of intracranial hematoma and MRI is not an easy one, owing to the changes that occur within the hematoma itself, from oxyhemoglobin, deoxyhemoglobin, methemoglobin, and finally hemosiderin. Each one of them has a different impact on the magnetic field of MRI, and this results in a different look of hematoma, especially in sequences of T1 and T2. Let's at first clarify some definitions. Hematoma within first 24 hours is hyperacute hematoma. 1 to 3 days, it is called acute hematoma. Subacute hematoma from 3 up to 14 days. 3 up to 7 days is called early subacute hematoma. 7 up to 14 days, 1 up to 2 weeks is called late subacute hematoma. More than 14 weeks is called the chronic hematoma. Sometimes the window of 14 days, according to some authors, is extended up 28 days. So late subacute hematoma may extend it up to 28 days, and the chronic hematoma, it will be more than 28 days. At first, let's talk about types of intracranial hematoma. We have generally 4 types of intracranial hematoma: the epidural hematoma, subdural hematoma, subarachnoid hemorrhage, and intraparenchymal hematoma. The epidural hematoma is lens-shaped, and mostly it is traumatic, and it presents in acute form. Subdural hematoma is a C-shaped one, and it can occur in acute form, post-traumatic, and the chronic subdural hematoma. Subarachnoid hemorrhage, the most common cause is trauma, and it has also a spontaneous form. It fills the sulci of the brain, and it fills also the circle of Willis. It occurs within the parenchyma of the brain. This is a spontaneous intraparenchymal hematoma, a basal ganglia hematoma. Sometimes it has an intraventricular extension. Back to the original question, which is how to pick up the diagnosis of intracranial hematoma and MRI. Due to the changes that occur within the hemoglobin, oxyhemoglobin, deoxyhemoglobin, methemoglobin, and hemosiderin, and this has an impact on T1 and T2 signal, it will be difficult to memorize this table. And even there are some mnemonics about the diagnosis of intracranial hematoma. However, when you are placed in a situation in the front of a patient, it will be difficult to pick up the information from table or some mnemonics to diagnose the hematoma and identify the stage of the hematoma. The main idea behind my algorithm is that CT is more sensitive than MRI in diagnosis of intracranial hematoma, whether it is an acute or hyperacute stage or chronic hematoma. If a patient presented in the emergency department, whether neurology or neurosurgery, with signs suspected of stroke or focal neurological deficit or seizures or head and head trauma, and you need to do an imaging, you will go for CT without doubt, because the CT is highly sensitive in diagnosis of acute hematoma, like this one: traumatic epidural hematoma, traumatic subdural hematoma, and subarachnoid hemorrhage and intraparenchymal hemorrhage. There is no doubt that these cases are easily diagnosed with CT. So MRI will be tricky in the early and the chronic cases, and this is the main idea behind my algorithm. MRI will be difficult to pick up the diagnosis in hyperacute, acute, and the chronic hematoma. If you ask yourself a question, why subacute hematoma is the golden time for the diagnosis of intracranial hematoma in MRI? This is simply because the MRI gives an hyperintense signal in T1, and the differential diagnosis for lesions with hyperintense signal in T1 is very limited. While in hyperacute and acute hematoma, it will be an isointense to the brain and can be easily missed. And in chronic hematoma, it will be hypointense in T1 and can be also missed. These are some examples to clarify what I'm going to say: that a patient presented with acute neurological deficit, symptoms with stroke, and CT was done in emergency department, it can pick up this is a basal ganglia hematoma, and this is a thalamic hematoma with an intraventricular extension very easily. And this is a patient presented to the emergency department with isolated head trauma. He had a left frontal epidural hematoma. If you look in MRI T1 sequence, you will find an isointense lesion and can be easily missed. And as I mentioned before, the CT is also sensitive in diagnosis of most chronic subdural hematoma. You can call it also subacute subdural hematoma, I agree with you. And the CT can diagnose it as well. And also this is a case of left chronic subdural hematoma. And it is very clear that the CT can pick up the diagnosis very easily. Now, back to the algorithm. MRI is the best in subacute stage, because the hematoma will give a bright signal, hyper-intense signal in T1. Then you have to look at T2. If it is a dark signal, hypo-intense signal, it is an early subacute hematoma. And if it is a white signal, bright signal, it is a late subacute hematoma. This is T1 sequence and this is T2. T1 sequence and this is T2. Hyper-intense signal, bright in T1 and dark hypo-intense in T2. This is an early subacute hematoma with the onset from 3 up to 7 days. Bright signal in T1 and bright signal in T2. This is late subacute hematoma with the onset of hematoma from 7 up to 14 days. This is T1 sequence and this is T2 sequence. Bright signal in T1 and bright signal in T2, hyper-intense in T2, hyper-intense in T1. This is late subacute hematoma with the onset of hematoma from 7 up to 14 days. This is a mixed hematoma. This is T1 sequence. This is T2 sequence. On the right side, the patient has bright signal in T1 and also it is bright signal hyper-intense in T2. This is a late subacute hematoma with the onset from 7 up to 14 days. On the left side, this is an hypo-intense signal in T1 and bright signal hyper-intense in T2. This is a chronic subdural hematoma with the onset of symptoms more than 14 days. Now let's come to the acute stage. As I mentioned before, CT is superior in the diagnosis of acute or hyperacute hematoma. An MRI you have to search for it because it is an iso-intense, which is similar signal to the brain in T1. And T2, if it is a white or bright, this is an hyperacute hematoma. And if it is a dark or hypo-intense, this is an acute hematoma. This is the first example, T1 sequence, T2 sequence. Iso-intense lesion in T1 and hyper-intense in T2, bright in T2. This is an hyperacute hematoma with the onset of hematoma within 24 hours. The second lesion is iso-intense also in T1 and it is dark in T2, surrounded with edema, hypo-intense in T2. This is an acute hematoma with the onset of symptoms within 1 to 3 days. Here is another example of acute hematoma. This is an iso-intense lesion in T1, similar intensity to the brain. It is difficult to pick it up. And it is dark hypo-intense in T2. This is an acute hematoma with the onset of this hematoma from 1 up to 3 days. Now, let's come to the chronic stage. CT can detect most hemorrhage also, as I mentioned before in the example of chronic or subacute hematoma. MRI is tricky because in T1 it will be dark signal like this one, and T2 it will be bright like this one. So this is a chronic hematoma with the onset of symptoms more than 14 days. This is an example that I was mentioned earlier. This patient has a bilateral subdural hematoma on the right side and on the left side. On the right side in T1 sequence it is an hyperintense in T1 and hyperintense in T2, so it is a late subacute hematoma. And on the left side, chronic subdural hematoma, hypointense signal. The intensity is lower than the intensity of the brain itself, and it is an hyperintense signal in T2, so it is a chronic subdural hematoma on the left side with the onset of this hematoma more than 14 days. To sum up, intracranial hematoma can be easily diagnosed in MRI in subacute stage, whether it was an early or late, because it gives a bright signal in T1. And as I mentioned before, lesions with a bright signal in T1 are very limited. While hyperacute and acute hematoma, it is an iso-intense signal in T1, and in chronic hematoma, it is an hypointense signal in T1. And you have to look in T2 to confirm the diagnosis and the stage of the hematoma.